in students, interns, and then also in registered dietitians. And so obviously we will be talking about eating disorders pretty much throughout the entire presentation. So if that is any kind of trigger for anyone, I will most definitely not be offended if you feel the need to step out at any point during the presentation. So a brief overview of my presentation today. We'll go over why I chose orthorexia, a brief review of what it is, the 3 research articles I will be underscoring, and some summaries and takeaways. And then at the very end, we'll have time for questions. So why orthorexia? So I remember learning about this topic early in my college career, and it wasn't really by a class. It happened to be a short Dr. Phil video I saw on social media, and it caught me a little off guard. And I know Dr. Phil is obviously not a reliable source, but it was ultimately what brought me to this term and what helped me learn a little bit more about it. And so it gave a word to some of the newly found anxieties that I was developing over food early in my college career. I remember being super stressed after my freshman year and being shocked over the amount of weight I had unintentionally lost. And I didn't immediately tie this to my eating habits at the time, because in my mind, I was being healthy and just super cognizant of what I was eating. And it wasn't until I learned about this pattern of disordered eating that it kind of clicked in my brain that I needed to reevaluate how I was eating. And so throughout this presentation, we'll see how being well-versed in nutrition may actually put us at a higher risk of falling into these behaviors. So the word orthorexia comes from the Greek words orthos, which means right, and rexia, which means hunger. And it is the fixation on righteous eating, and the judge of what is deemed healthy is the affected individual themselves. The term was coined in 1998 by Dr. Stephen Bratman, who was a physician in California, and he began noticing these issues not only in his patients, but also in himself. He began to notice the ways that these symptoms would affect people in the long run. And so a person's self-esteem slowly becomes wrapped around one's ability to adhere to what this version of healthy eating is that they've made up in their minds. And unfortunately, some of these rules are not harmless, and they lead to stricter, more harmful rules. And like all other eating disorders, it is life-consuming. In a lot of the articles that I read, they compared a orthorexic patient's fixation on being healthy to an anorexic patient's fixation on being thin. And so a snippet from a handout from the National Eating Disorders Association. Orthorexia nervosa is recognized by the National Eating Disorder Association, but it is not yet recognized by the American Psychiatric Association. So what this means is that even though the term and the knowledge of this pattern has been around since about the 90s, the complexity and signs and symptoms just haven't been narrowed down enough. And this is what hinders it from becoming an official diagnosis. But by answering yes to many of these questions, we can begin to see how the symptoms might be hard to pick up on, as many of them are internal battles that people fight. And even some of the symptoms that may appear on the outside are easy to pass off as a simple effort to be a healthier person. And so my first article that I'll be going over is, and it snowballed from there, the development of orthorexia nervosa from the perspective of people who self-diagnose. And at the bottom here, we see some abbreviations that are helpful to know that were used frequently throughout the study. And so it is research from 2020, and it's conducted by the Athena Institute and various other institutions across Europe. And I chose this study to touch on the effects that social media has on orthorexia. It covered other eating disorders, but orthorexia specifically. And this study found that its participants on Instagram, and it aimed aimed to study the development of orthorexia nervosa in people who self-diagnose. They were looking to gain insight on risk factors, symptoms, and how recovery begins for patients. And it also explored to see the differences from those who are exposed to the same media but choose to self-diagnose and those who do not choose to self-diagnose. And this was in an effort to find commonalities and hopefully narrow down what some of these diagnosing criteria can be. And so as we can see, the study was able to reach people from all over the world, and Instagram users were found through posts using #orthorexia, #orthorexia nervosa, and #orthorexia recovery. This gave them a pool of about 15,000 participants, which then they reached out to and gathered a total of 185 participants between the ages of 16 and 50. And so the survey consisted of yes or no questions that gathered info on their background and family histories and some of the symptoms that are associated with orthorexia nervosa. The second part of the boarding process to this study consisted of a longer, more in-depth 40 to 60-minute interview that aimed to gather more information on the participants and tried splitting them into 3 categories, which were journey into onset, progression, and help seeking. Again, this would hopefully define some diagnostic criteria. Their data was then exported and analyzed for prevalence and mean and median scores for the presence and intensity of different drivers and symptoms. And so here's a snapshot of the history information that was gathered. The asterisk results over on the very right side are those that were significantly different among the self-diagnosers and those who did not self-diagnose. And we'll review those in a second. So differences between individuals who self-diagnose and those who don't self-diagnose can inform the researchers and the search for a threshold between benign eating and orthorexia nervosa-like symptoms. For example, self-diagnosers were more likely to feel confused on what to eat following exposure to conflicting media seen on Instagram. And on the other hand, those who were not self-diagnosing found no anxieties when it came time to pick different parts of a meal. And so during self-diagnosed orthorexia, participants developed obsession and restrictions, which usually resulted in some form of biopsychal dysfunction with usually some social isolation, deterioration of relationships, which were the most psycho-distressing aspects of the disorder. And unfortunately, the findings from this research was congruent with past similar research. It found that those who self-diagnose typically live in a Western context in which they are exposed to social cultural ideas that value thin, healthy presenting bodies. And participants who self-diagnose reported that orthorexia nervosa develops gradually, and it's driven by interacting and mutually reinforcing contextual and biopsychal interpersonal factors. And on the slide, we can see some of the different questions that the researchers were trying to find. And so the answers to those. So as we can see, the first question was, how is orthorexia nervosa conceptualized by those who self-diagnose? And so in the following statement, the italicized words are words that were commonly used by the participants in the free text box that they were provided in their initial survey. So when they were asked to define what orthorexia nervosa was to them, many of them used the italicized words, and the percent that follows is the part of the population that used those specific words. So as we can see, it was described as an obsession with eating healthy, clean, or pure foods. They also said that eating anxiety and unhealthy effects on physical, mental, or social well-being are common among them. And so the next 2 questions about what biopsychal, interpersonal, and contextual factors contribute to orthorexia nervosa and what the differences are between those who self-diagnose and those who don't self-diagnose. And so as we saw on the previous slide with the asterisks, those that had history of eating disorders, psychological problems, food intolerances or allergies, family histories of eating problems, and family histories of psychological problems were all significantly more at risk of developing orthorexia-like eating patterns. And then their final question, how orthorexia nervosa and subsequent recovery are experienced by those who self-diagnose. So some participants self-diagnose when they realize that there's a large amount of anxiety surrounding their eating and their thoughts about eating, but then some barriers that happen after this realization include the lack of knowledge, even from health professionals, and the lack of an established treatment. And so at the bottom here, we see a quote from one of the participants, and it says, "In Ukraine, they don't believe in mental illness. There are some therapists and they're willing to help you if you pay tons of money, but they don't really care about you becoming mentally healthy." And this is not in any way a direct criticism on the Ukraine, but I thought it highlighted how even in a health setting, it is not a very acknowledged disorder that people are going through. They don't feel support once they realize that they're suffering with this. And so I think this research article is moving in the right direction. It is a very focused approach at finding commonalities between participants who self-diagnose in an effort to find some of the criteria that we need for an official diagnosis. It earned an overall positive score from the EAL scoring, but some of the limitations include that all of the findings were self-reported responses. And again, this goes back to not having official criteria, so we can't rely on anything other than self-reported responses for the time. So again, we have to rely on that self-reported data. Some other criticism is there was no control over participants for other non-orthorexia nervosa comorbidities. And then just to wrap up, a few quotes that I thought were worth sharing. So I really immersed myself on Instagram and learned all I could about nutrition. And the more I learned, the more confusing it got. I tried pretty much any kind of diet and then progressed, and I kept learning more and more about nutrition, and I got more restrictive. So this again underlines how sometimes becoming more knowledgeable on nutrition may lead us down a path of more restriction. And then the last quote, "Nobody really knows what the best diet is. There are so many fad diets out there. So really social media plays a big part, like me, who was confused really about diet. So I feel that played upon the mental aspect." And so to summarize my feelings on that quote, there is so much conflicting messages that we see on media. Oftentimes we see people we trust or celebrities that we follow sharing marketing information disguised as health advice. And we are seeing that can be very harmful for people who don't have a nutritional education as well. And so for my second article, food addiction, orthorexia, and food-related stress among dietetic students. So this study was done in a Greek university, and it pooled participants from their nutrition and dietetics departments. And this now explores how students in their program are also affected by orthorexia nervosa-like patterns. And at the bottom, again, we see a few helpful abbreviations that will be helpful to know for the study. And so I want you guys to take some time, especially as the holidays are coming up, or we start gathering with family over break, how some of these simple little comments are actually a little bit harmful for us. So something I get a lot is the "help me lose weight. I want to be healthy and look like you." And so something that then makes me think about is, should I be practicing what I preach? I don't think I am in any way the perfect image of what healthy eating is. And my least favorite one, I think, is the look at what the dietitian is eating. This usually comes after I grab maybe a second helping or some harmless dessert. And again, I know it's harmless, but it makes me sort of internalize some of those orthorexic-like patterns that I'm supposed to be perfect, even though there is no such thing as perfect eating. And the last one, aren't you supposed to be the healthy one here? As if there is some definition of what healthy looks like for everyone. And so again, there's a lot of internal pressure that we already have while learning about nutrition, but I think this exercise shows some of the external pressure and some of those external forces that also make us think a little bit harder about the dietary decisions that we make in front of other people. And one of the first points that this study brings up is that we are even more prone to developing orthorexia nervosa-like thoughts due to the constant exposure that we have, both in the academic setting or in our work settings, but also by those around us. And I provided this table to compare findings from different universities who ran similar studies within their departments. And so as we can see across the board, pretty much no one is immune. But some things to note is the BOT and the ORTHO are different scorings used. And like I said, no one in the nutrition fields were safe from orthorexia nervosa. In fact, most groups had a majority of their students presenting orthorexia nervosa-like patterns or thoughts. And I thought it was specifically interesting to look down at the bottom where we see the USA findings. It says that orthorexia nervosa prevalence was lower among long-term students compared to more recent ones. And I thought that was interesting because I feel that aligns with me. Being exposed to those early dietetics assignments that included things like keeping a food diary, using apps to track our macros and micros for a few days, they kind of stayed with me for a while, and they made me obsess a little bit about what I was eating and how much I was eating, and how made me really microanalyze every single little calorie that I was eating. It made me feel like I was to be the personification of my nutrition textbooks. And so this study, again, sent out a questionnaire to students within their nutrition courses. The questionnaires were then evaluated by the BOT, or the Bretman test for orthorexia nervosa. They then received a code, which was then to be taken into a lab to measure their anthropometrics. And some of the anthropometrics measured were BMI, waist circumference, and widest section of hips, all while standing. And this table shows the differences in anthropometrics, their dietary intake, food addiction, and food-related stressors. And something to note, at the very right of each value is the standard deviation values, and these indicate that the data was spread out pretty far from the median, which means it's not entirely reliable. And so, but as we can see from these results, age was positively correlated with the appraisal for outside stressors. And so what this means is that older students who have spent more time within the field are more likely to be able to cope with some of those outside stressors. And this aligns with the findings from that USA research that we saw in that first table. And I thought it was interesting to see how they compared both people who identified as men and women, and how they compare in the field. And so this table shows that there's no significant difference between the amount of men and women who are presenting with orthorexia nervosa-like patterns or thoughts or food addiction. And an alarming number in this table is the 68% of students who were presenting with orthorexia-like thoughts and eating patterns. This is more than half. And again, I think that it goes so undiscovered because a lot of the times we just think it's simple eating habits that people are doing to try to be healthier. And so the study indicates that there's a great number of dietetic students in their sample that were prone to orthorexia nervosa. And a quote from the researchers is, "Dietetic students carry the multifactorial burden of learning nutrition and health information, conforming to the healthy ideals and providing a role model." And to me, them acknowledging that was them acknowledging that it is known that these issues are more prevalent among our peers as nutritional professionals and students. But then there is not really a support group or active efforts in order to address this or provide anything similar to therapy for students who are going through this. And so some good things about this study is it addresses the continued battle that dietetic students have with addressing our own disordered eating. Some of the limitations are that, again, it pools their participants from a single university, and it didn't do too good of a job at addressing a lot of their prior history with eating disorders or family histories. And this study, I gave it a negative EAL score. The writers themselves at the end advised that because their samples weren't stratified, caution should be taken when generalizing their findings. And again, I don't feel like their outcomes were entirely reliable because of those very large standard deviation numbers. And so for my third article, Orthorexia Nervosa and Eating Disorder Symptoms in Dietitians in the United States. And again, some helpful abbreviations at the bottom. And so this study now aims to find the prevalence of orthorexia nervosa and eating disorders in the US, but now among dietitians. So sometimes we feel like once you get that RD credential, like you made it, you're done, you don't have to worry about this anymore. But they were looking to see if the training in making optimal food choices continues to become internalized in a negative manner, as the two previous research studies found, or if it kind of follows along with those USA findings that those who spend a lot longer in the field become better at coping. And so some of their methods, the Commission on Dietetic Registration provided the researchers with a sample of 2,500 email addresses who they reached out to. They all received an invitation to participate in the study via email. And those who chose to participate then filled out a few surveys, which were the ORTO 15, which is a 15-item questionnaire designed to determine the risk of developing ON. And the questions consider the impact of eating beliefs in terms of health, ruminative behaviors, and self-esteem. And the Eating Disorder Examination Questionnaire, or the EOT, included 28 items that measured eating disorder cognitions and behaviors that have happened within the last 28 days. And this includes questions that determine eating concerns, weight concerns, and dietary restraint. So this table shows the characteristics of the 636 RDs who followed through with the study. And in a second, I'll explain what the titles at the top of the slide mean. And so this is the second half of that table. And so the eating disorder questionnaire, again, is the one that included those 28 items, and the goals were to find their likelihood of developing either eating disorders or orthorexia nervosa. So a score on the ORTO of 40 or lower indicates that an individual is at risk of developing orthorexia nervosa. And then the EDE presents that a score of greater than 2.5 is considered that threshold that is meant to identify clinically relevant symptoms of an eating disorder. And so then DHC at the top was the healthy comparison dietitians. So this was those who scored greater than 40 on the ORTO and had no prior eating disorder treatments. And then the DON, which were dietitians at risk for orthorexia nervosa based on their ORTO score of 15, less than 40. And then the DED, which were dietitians who reported lifetime treatments of an eating disorder. And so sort of a summary of that big giant table of what we can gather from it is that 49% of the participants were at risk for orthorexia nervosa. And the scores for the EDE suggested that 12.9 were at risk for an eating disorder in general. And unfortunately, this is consistent with previous research within the RD population that they are not immune from developing these. And symptoms from the orthorexia nervosa group were closely related to eating disorders in this population. And so why this is alarming is that similar to the similarities between the dietitians who presented symptoms of ON and those who reported lifelong treatments of EDs is alarming, because that means that they then share the risk. There is a worry that they share the risk for the increased mortality that is associated with eating disorders. And so I thought that this study did a good job at addressing the continued battle that registered dietitians have with addressing with their own disordered eating. But some of the limitations are that it addresses any history of participants, and it was a declassification study, so this received a neutral score. And so some final summaries and takeaways. I think we can all agree that an official set of diagnosing criteria is necessary. This would allow for better research that didn't rely solely on self-reported data. This would allow for further, more accurate research on comorbidities that are associated with eating disorders and seeing how these are specifically related to orthorexia nervosa. And I think this can be achieved by funding more of the research similar to our second study, which was a very focused approach at finding commonalities among those who self-diagnose. And again, something that all of these studies underscored is how unfortunately common it is in our field at every step, whether it is at the student stage, at the intern stage, or at the official registered dietitian stage. We are not immune, and we are actually more prone to developing some of these thoughts and behaviors. And so the takeaway that I want you guys to go with is the challenge to recognize, more actively recognize if we are perpetuating any of these thoughts within our friend groups, our coworkers, or even in our families. I think a lot of times simple comments like the ones I showed in the previous slide, people get away with them, and they make us internalize things, and they also make those around us internalize things. And just to remember that we are not immune to orthorexia nervosa or any eating disorders, and that we are in fact far from it and are more at risk. And so here are my sources, and we have time for any questions that you guys may have.
Thank you, Cecilia. Like I said earlier, and like Cecilia said, go ahead and put any questions you have in the chat, or if it's a longer question, you can go ahead and unmute and ask it out loud.
May we see the reference slide again, please?
Yes.
Thank you so much.
Yeah, no problem.
Okay, so it looks like we've got a question. I'll go ahead and read that out loud for you, Cecilia. It says, do you anticipate that with this emerging research, there will be a change to curriculum taught at the undergrad and graduate level? And if so, what topics do you think might be covered?
I'm hopeful that it does, especially, I mean, some of the thoughts that I guess come up with why it hasn't been addressed yet are include knowing that this has been around or like officially recognized by physicians since the 90s. So it kind of makes me question, like, why isn't it already being taught? I think maybe some of the courses that can be included. I don't even know if we can, how long it would take to make courses around this, but I think even just professors being more cognizant that this is a thing, and maybe giving more disclaimers when these assignments come up, like offering alternative assignments. I know my university started doing that, so that was really helpful for our students that were suffering with these kinds of patterns. But I don't know, maybe even stepping away from those like self-examining assignments and giving more like case study work, because I know I never wanted to be the student that was like, can I please have an alternative assignment? Because that was kind of admitting that I had an issue with this. So maybe just stepping away from the self-evaluating assignments is a good start.
Okay, the next question is, did your second research article comment or compare dietetic students to non-dietetic students in the prevalence of orthorexia?
No. So that was, again, one of the limitations to that study. It only addressed students within their nutrition and dietetics programs.
Okay, well, if there are no other questions, then I will go ahead and stop the recording really quick.